Oh, hey, Chris.
Hey Chuck, how are you?
Really well. How are you?
Fantastic. Beautiful Saturday morning in St. Louis. Hoping the weather holds out for today.
Yeah, absolutely. I'll date myself. My youngest turned 18 yesterday, and we had a nice celebration, which continues all weekend. Yeah, good times around the house.
So she just gets a weekend, whereas your wife gets a year. That's really interesting.
18 might be equivalent to 50 in one of the big birthday scheme of things.
That's pretty awesome. So congratulations to you guys. Does this mean she's leaving the house come the end of the summer?
It does, and I'll tell you, Talia and I are looking forward to empty nesthood for sure. And with FaceTime and texting, you stay in such close contact. It's doesn't it's obviously empty nesthood, but it's not daunting, at least to us at all.
I'm sure when maybe if we're still doing this a few years, maybe you'll have some additional reflections on what that's like.
And they might look different. They might look different. We'll see. We might get tired of each other, but we've been looking forward to this.
Fantastic. Well, congrats to you guys and a happy birthday. And I think you guys will enjoy the rest of the weekend for sure.
Absolutely. One of the things that this will allow us is a little more flexibility to travel. And that's one of the things we want to hit on this episode. There's some different travel to discuss, and I think we have a good episode planned.
Yeah, absolutely. So you want to talk about any upcoming travels you have, or do you want to go back and talk about your recent travels?
Well, I have two exciting trips. I almost never travel for a full week for work. And I have two full week trips. The first is this coming week. So we're recording this on April 29th. So I leave tomorrow for Israel for a week, never been. There's a joint American-Israeli hand surgery conference, which is the second of its kind. The first was in 1979.
Wow.
Yeah, so kind of crazy. There's a good group of American surgeons going, and just really excited about the history of the country and the dynamic of the country. And I don't know that it's ever a perfect time to travel there. There's a lot of political, um, shall we say, discussion going on now, but I'm really excited. And my oldest, to keep it in the family, is joining me. Jake's flying from New York to Israel, and he is able to do that because he got into medical school. So all good.
All right. Well, congrats to Jake. That's huge. And then that's such a fun opportunity to do that. I think probably on the pod, I talked about how at one point pre-pandemic, my last international trip was doing a similar trip with the American delegation, so to say, to a combined meeting with the Korean Society for Surgery they had, and went to Seoul and actually brought my father. So on a similar theme to what you're talking about, just slightly different variation on it. But you will not be the only WashU hand surgeon traveling to Israel. Is that true?
Yeah, well, Marty Boyer is one of the ringleaders for sure with Jennifer Wolf, the president of the Hand Society. And your close partner, and obviously mine, David Brogan's joining. I don't know his travel schedule, but David's definitely going to be there.
Yes, it'll be fun. What are you going to be talking about?
I was looking at the schedule. I seem to be the one to give two talks, which is obviously great. I'm traveling a long way. I'm talking one which was easy to put together. One actually I had to put together. The easy one is radial deficiency in the wrist. That's I've done some modifications because interestingly, one of the or maybe the thought leader who helped us use soft tissue distraction for radial deficiency at the wrist was an Israeli who described it in 1989 and said, I'm going to mention that. And I don't know if the person is still alive or not, but that may be a fun discussion over there. And then I'm talking about pediatric and adolescent scaphoid fractures, which was an
Oh,
interesting assignment. And it's been fun to put that together.
that's great. Well, are you and Jake going to have any time to explore, or are you heading right back right afterwards?
Yeah, we're going to have a couple days before. We get in on Monday and we have Monday and Tuesday. And then the meeting sort of starts Wednesday night with some lecture about, I think it's really a trauma lecture, which should be really interesting given their experiences. And then the meeting is Thursday and Friday. And then we have a little time Friday afternoon. And then Saturday we have some time and come back Saturday night and Sunday, respectively.
That's pretty exciting. And that's the
Yeah.
first of 2 week-long trips?
Yeah, the second is Minneapolis for the World Congenital meeting, which we have spent. This was originally scheduled, I know we've talked about it, but it's originally scheduled in 2021, pandemic delay. In retrospect, we had to this, we made a good decision. We were debating, having in 2022, and we ultimately decided to delay it for 2 years. That was the right decision. And it's come together really nicely. There were some anxious moments on, when people sign up for meetings like this. Our goal was 300 attendees, and we're almost there. So the finances were a little shaky for a while, but we look good. The meeting is going to be incredible. It's actually Wednesday through for me, it's Wednesday through Sunday morning because we have a study group after, but it's really Wednesday through midday Saturday, and really a great lineup of talks. So I will be really excited to be at this meeting. What about you? You got to be going somewhere.
Well, there's actually a little bit. I think by the time this episode drops, since we're trying to plan ahead, since you and I are alternating our weeks of travel, it seems by the time this drops, I will have probably been on my way or just back from the combined Asia Pacific meeting in Singapore, which is super
Wow.
exciting. I think I have told the story of how we/I was invited to this meeting when you and I were in London at FESH. But one of the meeting organizers, Shuman Dasde, is in Singapore, and he is a fantastic hand surgeon with an interest in your world of congenital and peds, and he's actually going to be attending your meeting in Minneapolis. But he was a hand fellow when I was a resident at special surgery. So he and I know each other from there. And he was kind enough to invite me to come over. I'm super excited to go to Singapore. Never been, and very excited about that. And along the family theme, my sister is actually going to be joining me because she's able to travel, and she is obviously super excited about that too.
Now, is this the sister who met up with you in Vegas?
Yes, same sister. It's
Oh,
it's
that's
nice to
awesome.
work. It's nice to work remotely, isn't it?
Yes, I have not been to Singapore either. I had one chance and timing wasn't right. So I look forward to hearing your thoughts. How long is that meeting?
The meeting itself is 4 days. It will be kind of an out and back on the back end of Memorial Day weekend. I'm on Memorial Day weekend call, and then one of our partners has been kind enough to cover me for the few hours that at the end of the holiday weekend where I have to be en route. So yeah, super excited about that.
Wow, well, that'll be great. Good. Well, we should we thank our sponsors?
We absolutely should. We absolutely should. And yeah, by the way, anybody that's listening at home, we do actually work. I think my schedule is crazy jam-packed the weeks that I'm here before I leave and the weeks that I get back. But and I'm sure yours is the same way.
Well, yeah, I think that's a really good point. Yeah, the RVU
These
expectations.
out of touch academic hand surgeons.
Yeah, that is so not the case. And not only that, I've learned to be a little better, but you don't want the stress of all of it to make it harder. But God, missing 2 weeks in a relatively short period of time is unprecedented. And I'm already paying for it, and I'm going to pay for it for a while.
Well, I mean, we've talked about this before on the pod about being guilty of the add-on clinic to make up for lost time. I'm trying really hard to protect the time that I need to for sanity and for academic reasons. Although my medical assistant has become very savvy at looking for OR and clinic time to fill the gaps because it is getting a little crazy.
Yeah, yeah. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
I think I can share. You have been talking with our friends at Practice Link about a new segment, which I think maybe whether or not they're involved, I think we should do it. I think it's a really cool idea.
Well, let's not get them off the hook entirely. I think it would be really fun to do. We had I want to when we start the segment, I will disclose the listener email in full. But we did have a great listener who wrote an email with a segment very reminiscent of an old NPR show that I used to listen to. I guess when it was in podcast form, but many listeners who are old like Chuck probably listened to it when it was in actual radio show form. So I am a little bit of an NPR nerd. So we will not give it away yet, but that's a little teaser, and I think it's going to be a really fun venture with our folks, with our friends over at Practice Link.
I didn't never knew it was in podcast form, but there is something about having a show, whether that's television or radio, that's on at a certain time that you have to try to work around to be there. Obviously, if you can't be there, you can't be there. And in the older days, you just missed it. Now you don't miss anything, and you can listen or watch at your own convenience. But I remember planning my days around this particular show, and really great stuff.
I mean, basically, the upper hand is going to be the equivalent of must-see TV in in the podcast generation. Not really. But have you had, so we talked about your amazing travel schedule coming up. Probably you've come back from a meeting recently. I saw a lot of buzz on social media about Pozna.
I actually only had a quick trip to Poznan. Poznan was in Nashville, which is about a four and a
What's
half.
Pozna, by the way?
Thank you. For those listeners who are blissfully unaware, the Pediatric Orthopedic Society of North America, which is a great group. It's a bit smaller than the Hand Society, and they really have two major meetings each year. This is sort of the scientific meeting, and it was in Nashville, which is 4.5 hour drive from St. Louis, just far enough to make me not drive. But I was debating that for a while, but I was there for less than 24 hours, and I went down for a great pre-course, well, sort of a pre-course. They call it a specialty day, and we had a hand specialty day segment, which was awesome.
That's great. Did you wait? I didn't know they have a second meeting. Is it like a social meeting or something every year?
It's called IPOS, which is
Okay.
in early December. It's really good speakers, and it is designed. It's not scientific presentations. It's not awards. It's just bread and butter, pediatric orthopedic surgery in various formats for residents, for fellows, for young attendings, for everyone to learn. It's an intense few days of really great stuff. So that is super fun as well. But Posna is the classic scientific meeting, and it was good. It was Nashville was great, and Dr. Lindley Wall, our partner, co-organized this session with Hilton Gottschalk, who's in Austin, and they had a great session with some scientific presentations and some case presentations, of which I think was really well received.
Yes, and our Dr. Wall, your partner in the congenital practice, and my partner in hand surgery. We should acknowledge that she is now an endowed professor at Washington University. It's fantastic, and has taken over your role as pediatric orthopedic surgeon in chief at St. Louis Children's Hospital. That's the fancy way to call of the chief of peds?
That sounds good to me. Yes, absolutely. Yeah,
That's
she's doing a great job.
That's pretty exciting. I saw, I know my feed is obviously biased, but I saw a very strong WashU presence at the meeting, both among faculty, trainees now, and then alumni from various stages in their career. So, congrats on all that you've done to build that legacy.
Well, teaser for a future episode, but building community is hard, but it's also incredibly rewarding. And we have a great alumni group of physicians, and we had a reception at Pause on Thursday night. I couldn't make it, but it was incredibly well attended. And just like you and I have talked about our hand society get together for WashU hand, it's so great when those things go well, and you really get to see people you care about and who have been a part of the program. And so that really is wonderful to see in Peds Ortho.
Absolutely. When you get to reflect on that, that's fantastic. So, how many people do you think were in the room for or do you think were attended POSNA in general?
I don't know the answer to that question. It's a great question. I have no idea. I don't
Probably in the
know.
thousands.
Yeah, in the thousands, but not multi-thousands. I would guess 1,000 or so, but that could be way off. Probably not fair to guess. I don't want to insult anyone if I'm way off. But, I know that you and I have talked about just meeting attendance in general, I don't think has rebounded. The Academy talked about that the attendance in Vegas matched 2019, which I think is an accomplishment, but certainly it's tough. And there were shy of 100 people in the hand specialty today, which is good. It's never been a segment that has a huge number of people. There's competing interest. And so you get people really interested in hand, but it's hard to pull other pediatric orthopedic surgeons away from other specialty days. So it was a good session in a good city with good friends. So it was fun. But you also have travel, and I'm really curious to learn about Chicago and what went down.
Well, the reason I asked you about the number of people at POSNA is that you went from a meeting in, thousands of people there to I organized a meeting for 20 people. That was That was
But
a very different experience. I mean, so when we received the funding for our multi-center brachial plexus prospective cohort study, the PLANET study, which I'm very proud of that acronym. It's probably the only acronym I will ever come up with that works, but it's the Prospective Longitudinal Assessment of Nerve Trauma, PLANET. I still remember the day that I came up with that was I was leaving the gym and going to Monday morning conference pre-pandemic, and I was sitting at a stoplight. It's like, I got it. This will work because all the other orthopedic multi-center studies seem to be themed on astronomy, so Moon and Mars, et cetera. So that was my contribution. So our Planet group, when we received our funding, we said we were going to have a study meeting once a year in person. Then, of course, the pandemic. So this was our first study group meeting in person. It's amazing. It was that the American Society for Surgery of the Hand was kind enough to host us. Chicago was the perfect location for a fly-in meeting because we've got folks coming from New York, Baltimore, Charlotte, Nashville, in Chicago, in Gainesville, on the West Coast, in Seattle, and Indianapolis. So people are coming from everywhere. So to have a fly-in or drive-in meeting in Chicago is kind of perfect. And the ASSH has wonderful offices, as many who are listening who may have dropped by know. Great meeting spaces and very economically efficient, I will say, meeting costs. So that was also huge. So yeah, we flew in a surgeon from each site. They have funds from the grant to do that, and then a member of the research team from each site in terms of a research coordinator, research assistant. And it was incredible. I mean, it was just, to have a group of, we had 9 brachial plexus surgeons all come together, very thoughtful people who we all looked at each other and talked very honestly and openly about what our shortcomings are. And it was amazing to have a group of surgeons of that caliber, some real names, be very honest and open. And there wasn't any chest thumping of this is how I do it, this is how you should do it. It was let's try to figure out how to get better. And we had a guest speaker from the president of United Brachial Plexus Network, who provided not only a great presentation, but sat in on all of our scientific type sessions where we were brainstorming and thinking about new ideas and gave incredible context. And that was invaluable to the meeting. So super fun, just a dinner on Thursday night, all day kind of meeting stuff on Friday, and people are out by late Friday afternoon.
That is great. Must have taken a lot of planning to put this together and make it as an efficient and productive meeting as it sounds like it was.
I'm very proud of the fact that we were able to pull it off efficiently, and there was no grumbling about we started too early, we started too late, we ended too late, et cetera. We kept us on time and called some audibles during the day to kind of work, go along with what the group seemed to want to do. I think as the meeting organizer, my biggest faux pas was getting dinner at an Italian restaurant on Thursday night and forgetting to order a pasta dish for the group, which was, I think, reflective of the fact that I'm trying to be a little better about that kind of stuff. But totally, if that's the biggest issue I have with the meeting, I think we've succeeded.
Yeah, that is a win. And so you have 9, you said 9 surgeons attended. You have 9 sites, or was everyone able to attend?
Yeah, so we had one site that had two surgeons attend. There was one site that did not have a surgeon attend, but had their physician assistant come, who was heavily involved in both the recruitment and the execution of the study. So it was fantastic. I mean, we had HSS represented, Johns Hopkins, Ortho Carolina and Charlotte, Northwestern University, University of Florida, the Indianapolis Hand to Shoulder Center, our group at WashU, and the University of Washington in Seattle.
And are there plans to enlarge the group, or is this the size that's will get things done and can sufficiently enroll?
I would love to hear your thoughts on that in maybe a future episode about because you've done some incredible work with the COUD registry. I think we're going to try to get bigger at some point. The group feels good right now, but I think we're obviously open to other surgeons who are thoughtful, seeing these patients, have an interesting approach to it. It's just a matter of at the end of the day, the brass tacks are getting the data in. And if you can't get the data done, then even if you're an incredibly nice person and I like you socially, I don't like having to lean on you too much to get the work done.
No, that's right. It's we have gone very slowly with expansion. I think it would be a great topic because I think these groups are have changed the face of orthopedics and orthopedic research, and incredibly important. So yeah, we should dedicate an episode to that for sure.
Well, maybe we should talk about some hand surgery.
I guess so. We have a good, I think you have a case you want to share, and I think we can have a really robust conversation. I'm looking forward to this.
Yeah, I think I may be tainting the well on peer review because this case that we're going to discuss is probably going to end up being some kind of case series surgical technique thing because we talked about this. I emailed our hand surgery group. So, you, Dave Brogan, Marty Boyer, Ryan Calfin, Marie Morris, and Lindley Wall. And I was like, look, how many of these cases have you done? Because lo and behold, I've done 4 in the last 3 years for some reason, at least 4 with good pictures. Which there may have been a day where the case wasn't going as smoothly and I forgot to upload the pictures. But FPL rupture after attritional FPL rupture after volar plating for distal radius fractures. It's something that is so commonly talked about as a complication of distal radius fractures. The frequency rates are published with some, obviously different levels of methodologic rigor. But then, and people say, oh yeah, you reconstruct it, but then nobody actually, there's very little out there about how to do it, which was frustrating because I remember doing my first couple of these and trying to look in the literature to see kind of what to do and what the experience has been and finding very little. And the resident I'm working with right now, Andrew Kuhn, is fantastic. He corroborated that when I asked him, what did you read for this case? He said there was very little. So I can present the case, in generalities, but this is an older gentleman, older than Chuck, who had a distal radius fracture fixed somewhere else in the St. Louis region, and even he doesn't know who fixed it, which is probably a good thing because, as you said, if you don't know your hand surgeon's name, that's probably a good thing. But he
Classic.
couldn't even remember. 10 to 11 years ago, volar plate of a prior generation. And the fracture itself has healed incredibly well, like almost anatomic position. The plate's distal though. And you and I have talked, I don't know if it's in this forum or in conference or wherever, about, you put the plate where you need to get the fracture fixed right. But if you know you're going to have to come back in the future, you have to remind yourself that you have to come back in the future to get the plate out. And granted, awareness of plate positioning and risk of attritional rupture of any of the flexor tendons has gone up in recent years. But I think that was probably recognized by when this plate was going in. But he comes in, randomly, 10 years after his ORIF by somebody else. And it's like, I can't bend my thumb. Didn't feel a pop, don't know what happened. And then, of course, it took him, 3 months to realize I should see somebody. So he comes into the office and we get x-rays. I mean, how do you talk to this patient? Fracture's healed well, the plate is distal. And it's pretty clear clinically that he's got a ruptured FPL, tenodesis, doesn't show any motion of the IP joint of the thumb.
Can we talk about some of the anatomy before we kind of talk about how this is dealt with?
Absolutely. So, I would love to hear your thoughts, but I think that so for those of you that are kind of new to the game or are not surgeons, when you typically most people when they do the surgical approach for a distal radius ORIF, if you're doing a volar plate, most of us will make an incision kind of right over the FCR tendon. You incise the volar sheath of the FCR, you retract the FCR, you incise the dorsal sheath. And the way that I do it, and instead of, kind of spending time identifying the long flexors, et cetera, I just kind of take a freer and I get over to the shaft of the radius proximal to the fracture, park that freer on the radial border of the radius, kind of right around where the BR is going to start to flatten. And then after putting the freer in there and establishing that plane, I put a Homan over there, which is a retractor that kind of hooks underneath the dorsal part of the radius. And that keeps my radial artery out of the way. And then I just take a sponge and bluntly dissect all the long flexors over towards, towards the ulna. And that shows us the pronator quadratus, which in many cases has been traumatized and is almost blown apart. But you do have to incise some of that pronator quadratus to get down to where you need to do your work for the plate. And some people early on, especially the hand weenies among us, would debate out whether to repair the pronator quadratus to provide a buffer between the plate and the flexor tendons. But that's kind of where it gets interesting. So do you maybe, I mean, I know it's not the focus of this episode, maybe you give some pearls about how you do the approach.
Yeah, I like what you said. I go through the FCR sheath as well. You do have to be careful about the palmar-cutaneous branch of the median nerve, which is classically between the palmaris longus and the FCR, but can be overlying the FCR, and you don't want to injure that nerve. It's not the worst thing in the world to injure the nerve, but patients don't like it and they complain about it. And then you work underneath the flexor tendons, as you said. I like your Homan trick. Expose the pronator. And, people talk about how do you release the pronator? Do you just do a straight incision? Do you leave a cuff to repair? Do you L shape it so you're distally going transversely across the radius? I don't think it really matters. And honestly, as you mentioned, it can be really traumatized in bad fractures. Um, it is relevant for this conversation though. So after you elevate the pronator, you fix the fracture. And I guess let's go back to pronator now, and then I want to ask you a couple of questions. I do try to fix the pronator, and there's some literature around this, but the reality is, I don't think it necessarily matters because the watershed zone, which is the area where things get a little tricky, and if your plate is really on that distal watershed area, it's probably prominent, and the pronator can't protect you. And so pronator repair makes some sense to me. It's definitely not mandatory, and I don't think it really keeps you out of trouble.
Right. Can I add one thing about that?
Yeah.
I want to ask you, are there ever any situations, are there any fracture types or clinical scenarios in which you say, definitely going to do this approach like I'm going to fix the pronator? Because there are a couple for me, but I started off like that. And when I was a resident, Scott Wolf had a nice technique where he would instead of just transversely releasing the BR off the styloid, he would longitudinally incise the BR, the brachioradialis tendon, and leave the volar slash ulnar portion of that BR tendon attached to the pronator quadratus and elevate that as a single sleeve so that you could repair BR back to BR instead of trying to repair a flat, squishy, traumatized PQ muscle back to somewhere on the radius or periosteum or something. Um, when I've said I'm going to go in and repair the pronator quadratus, that's the technique that I've used because I have not found muscle repair to be gratifying and enduring in any meaningful way.
It is highly variable for me. It depends on the patient age and obviously the nature of the trauma. I have variably had good success with just repairing it to the cuff, which is left behind. But whether you incise or elevate the BR, you can still use the BR, however you do it. The BR is just sitting there, and there's no negatives to using it as an anchor point for your repair. But I like that technique. It does make sense. As to your question about whether there are certain fractures where I on the way in, think about repairing the BR at the end. I don't know that I've thought about it that way. Which ones do you think about?
I think it's the one where I know I'm going to have to put my plate pretty distal. I think it was actually our conversation here with Dr. Orbe and his talk about how, he designed his initial volar locking plate to be placed on an anatomically reduced fracture. And I think over time, because you can, quote, get away with a lot of stuff, um, a lot of surgeons have accepted kind of taking a fracture in neutral or slightly dorsal tilt and then putting the plate on to hold that position, which again ends up working out okay a lot of the time. But if you do that, then you're accepting a plate that is inherently going to be more prominent and potentially pressing on your flexor tendons. So, I think before, if I knew that I was going to kind of accept a not anatomic reduction for various reasons, whether it was bone quality or patient morbidity or trying to kind of move the case along to get out of the OR if the patient was sick, that's when I think I would probably try to do something for the pronator quadratus. But now I think I've become much more exacting on the reduction I will accept. At least try to get some element of volar tilt to try to protect that plate from becoming prominent. So less PQ repair for me recently because I'm just trying to get a better reduction.
It's a really, really important point that bears emphasizing. So, a distal radius which heals in neutral or slightly dorsal tilt is fine. I think we all would acknowledge that. But if you are
Whether treated surgically or non-surgically.
whether treated surgically or non-surgically, and but to your point, if you're putting a plate on which is anatomically designed and you accept neutral or especially slight dorsal tilt, then you are almost guaranteeing that that plate's going to be prominent unless you bend the plate or do something. And that's a really important point. The only thing I would say that maybe my philosophy is slightly different or my understanding is slightly different is I don't think it matters if you repair the pronator in that situation because the prominence is distal to the pronator. But
Right.
I think it's a really important point.
Right, right. Do you think that matters? And I have some ideas on this, but do you think it matters the type of implant that you use? You don't necessarily need to say what you use or whatever, but I mean, I do think the designs matter.
Actually, it's funny because that was my question to you. We all say that these plates are interchangeable, and I know the manufacturers don't like to hear us say that, But in
Unless you want
reality,
to, unless you want to sponsor us. If you want to sponsor us, Chuck is willing to listen to, and we can talk about how great your plate is relative to other plates. Just kidding, not really.
um, yeah, I mean, to a certain degree, plates are interchangeable, but there are subtleties. And maybe in a perfect world we'd have a plate choice for each type of fracture or something. But there are differences, thickness, how the screws fit. There are absolutely differences. And I do think it matters. I really do.
I changed plates. I changed preferred manufacturer for plate some point in the last 5 years for a couple of reasons. One was actually customer service, which that company has that I moved away from has improved. But I was, starting at a new surgery, ambulatory site, and I needed trays to be stocked. And if the trays aren't stocked, I'm going to start looking somewhere else. And then also this newer plate that I've been using is thinner, which I think makes a difference. But one thing that I learned, not the hard way, but I just from like looking, in terms of complications, but like looking at it lying in surgery, I think that some surgeons really endeavored to get that quote home run screw up the styloid. And listen, if my philosophy, which is probably a bit of a hot take, is that if you're relying on a single home run screw to provide stability for your radial column, and the radial column matters that much, you probably should be putting some additional fixation on the radial column. While it looks awesome on X-ray to have the longest styloid screw, and I remember there was a competition, one of the attendings I was with in residency would, remark on, oh, well, this person put a so-and-so length styloid screw, and can you do that? I'm like, oh. Now I'm like, that doesn't matter. I don't know what you think about that.
That's
I'd love to hear your thoughts on that.
that's interesting. I think we should have an episode on distal radius fractures again because some of this stuff is good and we should repeat it or expand on it. I've never heard that honestly, and don't put any stock in the quote unquote home run screw. A home run screw for me, I think more about an olecranon fracture.
Right.
I don't think there's a single screw that is that vital for a distal radius. Now, it can be important, especially in the osteopenic patient or the multi-fragment patient, but that's new to me. That's new to
Well,
me.
achieving that type of the point of that was that achieving that type of fixation sometimes means that you're relying on the variable angle aspect that many plate manufacturers give you. So for those of you less initiating, we should have a different conversation about this. A locking plate has a fixed angle option in which the plate, you take the nominal angle that so that the screw head locks in 90 degrees to the plate. Now you have a variable angle option where you can work within, for example, 30 degrees on a cone and shoot that screw in a different direction, and then the screw head will still lock into the plate. What I've learned is that for this particular manufacturer, if you do the variable angle to try to get maybe a different angle on this, or different length on the screw, like a longer screw, the screw head will still lock into the plate, but it will sit more prominently. And I think for those radial sided screws, those are the ones that could potentially tickle and irritate and eventually attritionally rupture your FPL. And I always, for me, it has been, the FPL from what I've seen and not many of the other flexor tendons.
Oh, I think that's exactly right. And that point is well stated. I don't want to pivot prematurely, but I'm curious. I think we have said on this podcast that both of us in the immediate postoperative period mentioned to the patients that we may have to remove this plate. Your fracture required a little bit of a distal placement. Do you believe that you can monitor, palpate for crepitus or tenosynovitis along the volar forearm and decide whether you need to remove the plate? Or is it purely the plate is placed in a position that makes you worried, therefore you have to plan to remove the plate?
Good question. I talk actually about the potential for implant removal before surgery. And if there is a particular case in which I think that we need to remove it, I make sure to tell the family, tell the patient, and put it in my notes, honestly, to remind myself. Because once people start coming back at, 6 weeks, 3 months, et cetera, it's kind of hard to remember some of that stuff. In terms of how to monitor, I don't think we can reliably do it. There are case reports from all over showing this can happen immediately after surgery versus 10, 15, 20, or 30 years. I think there's a report from, I think it's from mainland China about this happening 20 years after RIF. So it's something that I worry about all the time. And when I'm kind of discharging patients from care after just radius fracture fixation, I say, look, I need to know if you feel when you're I actually palpate on them and I feel over their long flexors and put my finger there, and then I put their finger there, and then I extend their wrists and I say, if you're gripping, and I'll do it for the YouTube here, but I'll put my finger right before the wrist crease on palmarly, and I'll say, if you're gripping and you feel anything creaking or crunching, you need to call me because I'd rather know before it's too late. Because I'd rather get that implant out when the tendon's getting irritated versus, tendons starting to give. Now, that being said, I've only had one patient come back recently that I remember that actually did that, and I went and took out her plate, and the tendon looked completely fine. But I think the point for me on the exam is that it should be with the wrist and extension. There was a paper, I think it was an ultrasound paper, um, published in the last few years, and I think we've actually talked about it on one of the What's New in Hand Surgery episodes a few years ago, showing that wrist extension is a position that you want to check, for crepitus.
All well said. I do the same exact thing. And when you feel it, it's impressive. When you feel that crepitus or crepitans, theoretically, or accurately, it's real and you know it, and it worries me. But I think you can also have that rupture without ever having felt that. And I think your point about timing is really spot on. Is spot on. All right, we should definitely. We've been babbling for a while. We should talk about how you think about
Well,
reconstruction, shouldn't we?
it's because we kept talking about all of your extensive travels and it ate up half of the episode.
True, true. Good point.
No, so I don't know. I struggle with this because I looked in the literature and there really isn't. There's no definitive case series or surgical technique, or I don't know. I'm stupid for like divulging this idea, but somebody's probably gonna beat us to the punch by the time we get this written up. But there will be a case series coming from WashU at some point, whether or not it's the first one in the literature or not at this point. But Chuck, maybe we don't release this for like 6 months. But you know, there's very little out there. I personally do not think in this nature of rupture you're ever going to be able to repair it. I think you have to tell the patient you're going to have to use some kind of graft, and for me, that's typically going to be an autograft. And then, yeah, I've learned the hard way that you got to say it's probably going to be back in your carpal tunnel or beyond the distal stump. So you got to be, in terms of drawing out your incisions, which I typically do in the office and then in pre-op, just say, look, we're gonna have to do a carpal tunnel release. I may need to go out into your thumb to find this thing. I'll make as many incisions and as big of an incision as I need, but not more than I need.
Yeah, absolutely. You end up with a relatively sizable incision because you cannot repair these, and you can't repair them on the dorsal side either for EPL ruptures. And you often are either exposing the entire carpal tunnel or passing a tendon graft through the carpal tunnel. So I agree with that, and that's important to lay out beforehand. So number one question: so you don't do a tendon transfer. You're not going to do an FDS of ring finger to palmaris longus. You're doing an interpositional graft. Is that correct?
If I can, because I mean, so other people have asked kind of like, why not just do like BR to FPL? Because your tendon stump's going to be too far distal to reliably get into use the BR as a transfer, because that would be a relatively easy, straightforward transfer. But the FPL has such a huge muscle belly, and I remember Marty Boyer, one of our partners, talking about how the FPL is a huge muscle belly, and it just like I don't like to leave axons on the table. He doesn't like to leave any good muscle on the table. So I think that it is also independently innervated, which is huge. So I personally think that it's a better option than an FDS transfer, but I do think an FDS transfer would be a nice alternative or backup if you, for example, got into a situation where you couldn't get this thing to you couldn't get your tendon graft to reach for whatever reason, or you're like, this is no longer going to glide. What do you think about it?
I think that's well said. I have, no one has a ton of experience to your point. I've done interpositional grafts and I've been happy with it. But I do think FDS is a great backup if for whatever reason the interpositional graft is not going to work.
What's your choice of graft? And
Yeah.
is there any role for allograft here?
Oh, I don't think there's any role for allograft. There's no need for the expense, and I think there's plenty of options. So the way I think about it is palmaris is obviously easy and is fantastic as long as it's there. I assume you agree with that. That's the first choice.
Yeah, that is the first choice. But what do you do if the palmaris is not there?
Yeah, I mean, certainly you have the option in those patients that have a contralateral palmaris to do a small incision and harvest it. Not really been my first choice. I usually use a portion of FCR. So I have no problem harvesting half of FCR. I think it works. I think it's right there. And you certainly have plenty of length for almost every scenario. What about you?
Same algorithm. Not surprising to anybody. I think that most of us would make the same decision. Do you have any pearls on finding the distal stump?
No, I haven't done enough of these to have true pearls. I it's often in the carpal tunnel has been my experience. So you're hoping you find it, right near the plate, but that's not really what I have seen. And so what I typically do is I don't typically open the carpal tunnel because it's ultimately a great pulley in these situations. And so I go distally over. So I make an incision. Usually what I end up doing is making an incision where we know we can find the FPL just proximal to the A1 pulley. Because if you go too proximally in the thenars, it can be tricky to find it, at least for me. So I find it a little more distally, preserving the A1 pulley, and then I try to work back towards the towards we just had a hand raise because
It's
I'm
because you're raising
demonstrating.
your hand on
Yeah.
the camera. Zoom is
And
too smart now.
yeah, I work back towards the transcarpal ligament, but I like to leave the transcarpal ligament intact, and obviously got to be aware of those little nerves that you care so much about. Keep everything safe, but I do
You
try
mean
to
the
find
recurrent
it.
motor branch?
Well, that and the two sensory nerves are
Right.
both, they're all in play.
Yeah, it's interesting in this case. We actually, one of the points I make when we're starting the volar approach to get back in is that you got to find the median nerve from the beginning. I personally think that's important because I've gone in to take out volar plates before, and the median nerve was randomly subcutaneously or conversely scarred to the plate. So in terms of making myself feel better, I find the median nerve right away so that everybody knows where it is. And then in this particular case, we actually saw the palmar cutaneous, and it had its own classic little tunnel, just sitting on top of the carpal tunnel. So we kind of traced all that out. I think this is hard because, like you said, if you want to, you can. It's nice to leave the carpal tunnel as a pulley, but also I kind of get nervous because I'm almost always going to have a graft sliding through the carpal tunnel. So I think it's actually, my preference is to release the carpal tunnel. So I actually do that from the beginning. And in this particular case, I didn't have to go out in the thumb. We were actually about to make the incision to go out into the thumb. And then we did the classic like orthopedic milking maneuver where you try to, flex the thumb and kind of walk that thing down with, by pushing on it over the flexor sheath. And lo and behold, it peeked its head out into the very distal aspect. I'm like looking down into the carpal tunnel, like putting my head down, and it's just there, right there underneath the thenar eminence. So that was great because we were then able to start our weave. I started my weave distally with, in this case, a palmaris. I've had to use an FCR, a hemi FCR in the past. Got some really nice weaves. We put in some nice stitches in. And then I guess the question is, we passed the graft into the carpal tunnel, the shaft, or not the shaft, but I guess the non-woven portion of the graft into the carpal tunnel. How do you set your tension? Because I think this is something that I guess we'll have this discussion when we write this up, but this is not easy.
So first of all, you're doing like a pulver taff weave. Is that your goal? So you can start
Yeah.
early motion?
Yeah, we did a pulver taft and we're starting early motion. And I felt good. We got, 3 really nice weaves, not too bulky.
Yeah, the bulk is obviously key. I think about it with wrist position. And so I try to set my tension so that with wrist extension, the thumb is flexed and resting comfortably, a little firmly, but not too firmly against the middle phalanx of the index finger. And
So
with
it
the
hits for
wrist,
so it hits for pinch.
so it hits for pinch. And then with wrist flexion, the thumb is fully extended. IP joint is hyperextended even. And I always, we've talked about this. I always like it a little tight, but not too tight. And so it is an art, and tendon transfers just aren't done today as much as they used to be done. So it is a little tricky, especially when you're doing this infrequently, like we all are.
It's interesting. I have the pleasure of reviewing our fellows' case logs every month and have been reviewing case logs now for the last 2 or 3 years. And also nationally, the discussion is, we're not doing as many tendon transfers. I mean, our fellows' nerve numbers are off the charts. And some of that is the bias of what we do here, but it is important. I tell them, you got to go get your radial nerve tendon transfers. Like, when we do them, part of the experience here is trying to provide a balanced perspective and making sure, because I didn't see many tendon transfers in my fellowship year, because some of it's like kind of depends on who you work with and when you work with them and kind of the random lottery of that, but then also just general practice trends.
Yeah, really true. And I think we've learned that there are certain cases for whatever reason that are just not going to be seen frequently, and the fellows need to be there if they can. Thankfully, we have a huge volume of cases across the board, but we have our subspecialty biases. for sure.
Absolutely. So yeah, attention in a similar way. I'm not as generous of you about checking extension with the wrist and flexion. I really do care more about, what the thumb is going to do with the wrist and extension. And I have not done enough of these, nor do I think anybody probably has to have a standard therapy protocol. But I do think, we put this patient in so we also got some weaves proximally, and I'm less worried about bulk there. I actually reversed the tendon so that the skinnier part of the tendon that's less mop endy, because if you really get as much length on the tendon as you want to, you're really getting the superficial palmar fascia, so that but the skinnier and cleaner part of the tendon is coming off of the musculotendinous junction. So I trim that back and use that distally, so it's nice and to avoid the bulk.
Oh,
I know that
only a nerve surgeon would think about reversing the tendon.
reversing the tendon. Hey man, I'm trying to make this look good. We got as they told us in India, you got to take good pictures, otherwise they won't think you're a good surgeon. But pictures look good. And then weave that in proximally, got a really nice weave, set the tension after the first weave, made sure we liked it, or set the tension with the first weave and then checked it after the first weave. Um, Dorsal blocking splint, forearm based, with the wrist was just in neutral. But then, ran the thumb portion over the top, MP, IP in kind of the gentle flexion that I wanted.
Yeah, I love it. I mean, I think I don't rush to get movement in these patients, but I think either at 1 week or the typical 2 week follow-up, I start therapy. I do think it takes a while for this truly to incorporate, but I tend to keep them with that dorsal block cement for 6 weeks, and I don't truly release them until 8 to 10 weeks. But I think you can get really good results here, and patients seem to be happy. And the final thing I'll say is, you know, not every patient in my experience has chosen to reconstruct these. Most do, but occasionally you have a patient that just says, I don't think it's that big a deal.
Yep, I'd agree with you on that. I'm trying to remember how many patients have declined. There's definitely been at least one. He's like, no, I'm good. And I don't think it was exactly in this setting of a distal radius fracture, but I think it was some random attritional rupture. And he said, no, I'm good with what I have. I like the early motion within the confines of a dorsal blocking splint, mainly to get that, weave gliding through the carpal tunnel. And then, the tenodesis part, I think in a few weeks is very reasonable. So I'm a little more liberal than you. I'd love to hear from any surgeons, therapists, their perspectives on this, because I think that it's important to kind of see if anybody else has a broad experience with this. But don't publish it before we do.
And then the random hand surgery eponym query here is Mannerfeld syndrome, the
Yes,
attritional
the attritional
rupture
rupture.
of
Yeah,
the FPL,
maybe
not
this will be
commonly
gold.
seen.
Maybe this will be Goldfarb syndrome when we publish.
No, no, thank you. No, thank you.
Like a workman hammering his nails. But I guess to close, I mean, I think that you want to email the group. I was like, look, does anybody have this? Like, this won't be a groundbreaking, earth-shattering contribution, but I think it would be a modest contribution. And I think you had a really nice comment saying that it's these kind of, and then in quotes, simple end quote, studies that can help practice.
Yeah, I mean, I think Dr. Government taught me that, right? There are some studies that will impact practice that people will look for and reference, and this is one of those that you can make a difference in how people think about this issue. And residents and young attendings search for a paper like this to help guide them, honestly. And then there are other papers that have bigger goals, but I think this could be a nice contribution. Hopefully, we can, get some patients together and get some follow-up.
Yeah, let's not count our chickens before they hatch.
True. True.
All
All
right.
right. Fun. Thank you.
Have a wonderful day.
You too.